speaker, Dr. Sima Das, who's again a well-known ocular oncologist that India has, and she practices in Shroff's Charity Eye Care in Delhi. And she has mentored many people worldwide, and it's great to have her here for the next topic on congenital lesions of ocular surface and other tumors. Over to you, Dr. Sima.
Thank you, Farouz. Thank you, Dr. Hunawar, for this opportunity. So I actually modified my presentation a little bit, quickly changed some few slides so that we can just recapitulate what Farouz has just taught everyone. So this is going to be more of an interactive, maybe some question and answers so that we see how much we remember and just go through the whole thing all over again. So I'll be talking about some of the congenital tumors of the ocular surface and few other tumors and the different spectrums. So it's a huge list. The congenital lesions are mostly the choriostomas, different type of them. Vascular can be congenital. There are other lesions, some of those like the cystic lesions can be congenital. And then we have few other tumors. Some of these can be benign, some can be malignant. We have already gone through different type of presentation of the epibulbar choriostomas. They can be simple, they can be complex. So what is the diagnosis of this? We just saw some of the pictures. What do you think in this? Dermolipoma. So we know it's a dermolipoma. So dermolipoma, what is important to know, can have association, can have syndromic association. Both limbal dermoid and dermolipoma can be associated with the Goldenhar syndromes, and we know the features of the Goldenhar syndromes. So it's important to just look at the site profile of the patient also if we find a patient having an epibulbar choriostoma, either a dermolipoma or a limbal dermoid. More often than not, dermolipomas sometimes tend to be isolated, but there can be syndromic associations. So what is important to know? Do you operate on all dermolipomas? If a patient comes to us, what is important to know when we are planning the surgical excision? These are surgical treatment. So what is important to know? Do you chase it? Do you go excising all of it? Because some of it is going to actually extend into the orbit behind the fornix, most of the time along the sheath of the muscle, and some of them tend to be attached to the muscular sheath. Like for example, this is probably going to be attached to the lateral rectus sheath, and if you try to chase, we are going to end up causing so much of scarring in that area of the orbit, which is going to cause restriction of the ocular movements. So this is a cosmetic problem. We don't want to convert it into a functional problem of diplopia. So what's important to know is the excision indication is only for cosmetics purpose. We only do a very limited excision. We never chase it behind the fornix. Idea is to just make the area which is visible in the palpebral aperture clear and just leave behind the rest of the things. One more important thing, especially in the elderly age group, we have to differentiate it from the conjunctival fat prolapse or vital fat prolapse, which can sometimes mimic, especially if the patient is relatively younger. And we know the features of how to differentiate them. Just a small bit, we are talking about a limited excision. This is how we go about it. This was a syndromic patient with multiple conjunctival choriostoma along with the dermolipoma. So we try to find a plane between the conjunctiva. Whatever healthy conjunctiva is there, usually they will be adherent to the conjunctiva. But since it's not a malignant tumor, we really don't have to chase and try to excise all of it. A debulking is enough. So we try to excise the part which is just in front of the muscle insertion and try to avoid damaging the sheath of the lateral rectus or any other muscle. If the overlying conjunctiva seems to be keratinized with a lot of hair follicles, sometimes those are the causes of irritation, ocular surface, watering and all, so that part can also be excised if required. Otherwise, we tend to conserve the conjunctiva as much as possible. So what are these? What about the first one? The second one is pretty obvious. It looks like a limbal dermoid. What about the first one? It's not really into the limbus. It seems to be into the cornea. So both of them are again dermoid. Some of them can be totally into the cornea, also not really into the limbus. The second one is the more typical one. Sometimes there can be chronic changes also. And sometimes there can be hair follicle keratinization of the surface, which can cause ocular surface irritation, and that sometimes is an indication for surgery in this patient. So usually we go about excision if there is any cosmetic problem, but again here we have to inform the patient, especially if there is a lot of corneal component, that scar on the cornea is going to remain. So there is going to be white scar on the black part of the cornea, which they have to understand if the excision is purely done for cosmetic purpose. Otherwise, if there is an obscuration of the visual axis, there are findings like presence of hair follicles or keratinized surface, which can cause irritation of the ocular surface. We can go for excision. What about this? 15-year-old boy comes with this picture, and the mother says there is a lot of redness suddenly which has come up, and this lesion seems to be increasing in size. What does it look like? So this is again a dermoid, but sometimes they tend to get inflamed, especially in the adolescent age, where like we see the inflammation happening in the nevus. Sometimes the same thing can happen in the dermoids also. But the clue here is that you can see that white line in front of the lesion, which tells us that this is something which is very chronic. There is fat deposition here. And this is again a limbal dermoid with some amount of surface inflammation. Rarely they can be inflamed. So again, if cosmesis is a concern, one of the way to go about we excise any other dermoid before you, and if there is a deeper extension of the cornea, ensure that post-operatively is cosmetically little better. Excision with tattooing of the area where the corneal extent of the lesion was there, and the scar is relatively less visible here. So other important thing to recognize is that all these complex choriostomas, sometimes they can be bilateral, can be associated with something known as epibulbar linear nevus sebaceous syndrome, because those have implication beyond the eye. There can be systemic malignancies which can be associated with those syndromes, and we need to identify these syndromes, counsel the family, do the screening if required. This was a young gentleman, comes with a medial ptosis, medial droop, which has been there for a long time, increasing in size. What should be your next step of examination? There is a subtle fullness in the medial eyelid. So you evert the eyelid. This is what you see when you evert the eyelid. So what is your diagnosis? We have gone through all of these cases in the first presentation. What does it look like? This is the tarsal conjunctiva. So this was again a complex choriostoma. So it's not necessary that all complex choriostomas that we see will be in the bulbar conjunctiva. Some of them can involve the tarsal conjunctiva also. And a clue to the diagnosis could be, of course, the appearance gives a clue, but also a small subtle coloboma which can be there in the eyelid can give a subtle clue to the diagnosis. So we know that complex choriostoma can have various components of tissue. There can be cartilage, bone, lacrimal gland, many other tissue, fat predominantly. So is there a way to know which lesion will have more component of particular type of tissue? So histopath is a definitive diagnosis, but sometimes looking at the lesion, if it looks predominantly yellowish color, then we are looking at maybe epidermal or adnexal component with fat. If it is predominantly lacrimal gland component, like in the second patient, it looks more pinkish, reddish. If it is cartilage predominantly, sometimes the appearance can be a little bluish. So just a kind of broad algorithm, but of course histopath is required. Dr. Feroz has shown these pictures beautifully. These are the pharyngeal conjunctival retention cyst, implantation cyst, right? This was a young boy, I think 1 or 2 year old, progressively increasing bluish cystic swelling on the bulbar conjunctiva next to the limbus since birth. So what do you think it could be? So it's not that all conjunctival implantation or retention cysts which are present since early childhood or congenital are always in the fornix. Sometimes they can involve the bulbar conjunctiva. So what are you going to do for this patient before you plan any surgical excision? UBM is a must because these lesions, since they're present since birth on the bulbar conjunctiva, can cause some amount of pressure effect and thinning of the underlying sclera. Like we see in this patient, there is quite a bit of thinning of the sclera, and if we are not aware of it pre-op and prepare accordingly, we might end up with trouble intraoperatively. So these have already been covered. The vascular lesions, again, has been covered quite extensively. So I will just focus on one lesion. This was a middle-aged gentleman, comes with this history of bleeding, recurrent bleeding. This time it was pretty extensive. So what do you think it is? avascular malformation. So once the bleeding subsides, we give some symptomatic treatment, maybe some steroid, let the bleeding subsides, and what you see is that lymphangiectasia. So lymphangiectasias are those isolated dilatations of the lymphatic blood vessels, mostly informs the bulbar conjunctiva, and more often than not, they usually will cause ocular surface irritation and other problems. Sometimes little bit of chemosis of the conjunctiva can be the presenting complaint, and rarely they can bleed, especially if they get filled up with blood. So we need to know the underlying lesion and then treat them accordingly. Most of them will be either treated with sclerotherapy, or if it's a very small localized lesion like this, you can go for a surgical excision or even do a cryotherapy. These are again covered. So this also we have, Dr. Feroz has already covered. Young gentleman comes with this ptosis, progressive, and when you evert the eyelid, this is what you see. Any guess what it could be? It's again a very pinkish looking lesion, baby pink sort of lesion. Same what maybe a lymphoproliferative lesion looks like, but he's a young guy, very slowly growing lesion. So this we have already covered. Again, spot diagnosis. Phoenicial lesion, not the bulbar congenital lesion, but the similar color like the previous patient. Lymphoma, right? Sometimes it can be the conjunctival component or the subconjunctival component could be just the tip of the iceberg. The main lesion could be lying in the orbit, and it is important to recognize this lesion because surgical excision is not the treatment of choice for these lesions. They respond very well to radiation. There are chemotherapy regimes which are available, especially if it's bilateral or there are systemic involvements. So we really don't have to chase and try to excise them and cause damage to the normal orbital tissues. So these are conjunctival lymphomas, and we know the typical salmon pink color. It's almost diagnostic even without a biopsy. And treatment is radiation. They respond pretty well if it's an unilateral isolated lesion. So this was a young girl, again a salmon pink color, but she was 6-7 years old. Do you think it still could be lymphoma, or there are other possibilities? It's a little more pinkish. Dermolipoma will be more yellowish, and it's a recent onset, couple of months history as per the parent. She was otherwise okay. She was diagnosed as a conjunctivochalesis. Elsewhere, treated with symptomatic treatment, lubricants, steroids, and other things, did not regress, kept on increasing. We did a biopsy. So what is your diagnosis now?
Round blue cell tumor.
Yes, yeah. Acute leukemia. Lymphocytic leukemia sometimes can present in a child with a conjunctival. So a solid chemosis is the clue. So chemosis which is solid, it's not like, chemosis which you see in the conjunctiva, is a clue that it could be, especially in a child, either a lymphoma or a lymphocytic leukemia. Pardon? Yeah, orbit, all the workup was done because if it's a lymphoma, if leukemia is the diagnosis, most of the time the job of the ocular oncologist is to diagnose the lesion. The rest of the treatment and workup is taken care of by the pediatric oncologist. So this Dr. Feroz has again covered cost. I will just finish with these last lesions. So anybody who can pick it up gets a chocolate. What do you think? This was an elderly gentleman, 70-year-old. His complaint was this mass lesion which was progressively increasing, pinkish, reddish kind of lesion, and a lot of irritation, has been there for a couple of months, and this is the slit lamp appearance. Okay, anything else? It looks pinkish, fleshy. So we did a biopsy, but while we were doing the biopsy, before the biopsy, we decided to go ahead with an UBM because the sclera in that area did not look very healthy. So what do you see? You see what do you see in this area?
Calcification.
There is calcification. So what is the diagnosis now?
Cogan's plaque.
Cogan's plaque. So these are the senile, benign plaques, which are sometimes seen in the elderly patients, elderly individuals at the site of the muscle insertion. Sometimes they can cause a lot of thinning of the sclera with overlying inflammation, which can look like a mass lesion like this. And this was just I don't know if it's playing. Yeah, just a small clip just to show intraoperative. You can see this plaque, the calcified plaque, and look at the underlying thinning of the sclera. The UVA is all visible. So if you try to excise this sclera without a patch graft, probably patient will end up in trouble. So we had to put a scleral patch graft for this patient. So this was all. Thank you very much.
Dr. Sima, excellent presentation. Do you also agree that Cocan's plaque is something which we very commonly see?
Yes,
And it's usually thinning, like bluish thinning. But this has something on top. Is it
So it was probably an underlying inflammation. The plaque was very thinned out.
Yeah, that's the common presentation. Yeah.
Usually the common presentation, you see a little thinning of the sclera, you see that white plaque.
Yeah, the white
This is an overlying inflammation and a lot of granulation tissue on top of it.
Right. So you had a histopathology proven that it's inflammation.
Yes.
Inflammation happens in Cocan's plaque?
It does not. I don't know why it happened, but it was there in this patient. So normally so much of thinning probably is also not to the extent that you have to go for.
What was your differential diagnosis?
I thought it could be because the gentleman was 70-year-old, so I kept neoplastic
etiology, and that's why you went ahead excising
it. Squamous cell carcinoma as an etiology. That's the reason we went ahead with an biopsy.
Right, yeah. Thank you so much.
So dermolipoma is something like you don't have to go for a complete excision because it's a cosmetic concern. So the part which is visible within the palpebral aperture, we can go for a limited debulking. And depending on the extent of the conjunctival involvement, if there is a need for amniotic membrane grafting, we can do that. Not really. If our clinical diagnosis is dermolipoma and there is no other Yes, we do have couple of patients where there is golden hair with limit dermoid. That's pretty common. Golden hair has a lot of systemic associations, but most of the time our job is to kind of take care of the ocular surface, and if there is any syndromic association, the patient goes to the kind of either a genetic counselor for rest of the counseling and the physician for the systemic evaluation.
Can we